بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على رسوله الكريم سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. Dear colleagues, we are about to continue the series of DRE or Diagnostic Radiology in English, and we started to discuss the gastrointestinal imaging. We have delivered 2 lectures about the normal anatomy. Then we are starting 4 lectures about imaging of the gastrointestinal tract, considering the diagnostic value of barium studies as well as the role of CT and MRI whenever they are needed for the diagnosis. These 4 lectures will deal with imaging of the esophagus, imaging of the stomach, imaging of the small bowel, and imaging of the large bowel. Then the first talk will be about the imaging of the esophagus, and we'll start first by the value of the plain X-ray of the abdomen and also of the chest whenever we are introducing any contrast material into the gastrointestinal tract. We should do a plain radiograph for the part to be examined to ensure the quality of images and to see any abnormality before introducing the contrast material. Then the plain film has many diagnostic values. Through the plain film of the abdomen, we can identify radiopaque calculi. We can also see calcification, and we can identify the gas pattern of the intestine. We can also see radiopaque foreign bodies, and sometimes we can assess the presence of intraperitoneal fluid. This is the role of ultrasound mainly. Then intraperitoneal air and the enlargement of some of the organs, especially the liver and the spleen. And finally, to look at the skeleton for any abnormality in the spine, the sacroiliac joints, and in the pelvic bones. Here are some of the examples considering the radiopaque stones, and this is an example of a stone in the left kidney, and this is a staghorn calculus in the left kidney of another patient. And here you can see 2 faceted radiopaque calculi outside the renal shadow, indicating that these calculi are likely present within the gallbladder. Also, considering calcium, we can see calcification confined to the renal area, and this is what we call nephrocalcinosis. And in females, we can see this mottled calcification within the pelvis, diagnostic of calcified myoma or fibroid. Then gross or fine calcifications are at the anatomic site of the pancreas, is usually diagnostic of chronic pancreatitis, while calcification of the gallbladder wall is known as porcelain gallbladder, and this is, as you all know, a precancerous condition. Then also you can see calcification in the region of the appendix, which may indicate the presence of appendicolite, which is one of the signs of acute appendicitis, as we will discuss later on. Considering the gas shadow, here you can see that some of the proximal small bowel loops are distended with gas, and there is almost absence of the gas distal to this, suggesting an obstructive issue. Then the erect film showed some of the air fluid levels, and this confirms the diagnosis of a small bowel obstruction, which is mostly in the proximal small bowel. Then if you look to this erect plain X-ray of the abdomen, and you can see that the colon indicated by the hostra and the peripheral location through the abdomen, the colon is distended with air, and you can see multiple air fluid levels indicative of chronic obstruction. Then the CT scan of the same case showed that this obstruction is due to the presence of a malignant stricture in the sigmoid colon, giving the typical configuration of the apple core appearance, and you can see here indicated by arrows. Then intraperitoneal fluid was suspected by the obliteration of the flank strip fat. In normal conditions, in the X-ray of the abdomen, you can see a radiolucent line along the lateral abdominal wall, and this is known as the flank strip or the fat strip. Then the presence of significant amount of intraperitoneal fluid may lead to obliteration of this flank strip of fat, but actually you know that the diagnosis of fluid is much easier using ultrasound and CT scan. An intraperitoneal air is diagnosed simply by having a chest X-ray in the erect position. Then you can see that this is the diaphragm, and you can see air under the diaphragm. This is diagnostic of pneumoperitoneum. But if you cannot have this chest X-ray in the erect position in some cases, you may refer to this important sign, which is known as the regular sign. And the regular sign means that you can easily identify by the plain film the wall of the intestine. And if you can see the wall of the intestine, you know that there should be some air outside the lumen together with the air normally present in the lumen. Then you can see the wall of the bowel. But usually you can only see the gas within the bowel loop, but you cannot see the actual wall. If you can see the wall, then you know there should be some air outside the bowel, and this is diagnostic of intraperitoneal air. And here you can see an example of a huge spleen, which is easily identified in the plain film in this child. The spleen is reaching the left iliac fossa. And this is an example of a radio-opaque foreign body near the ileocecal junction or the ileocecal area. And this is also an example of some medications which are seen in the region of the stomach. And here you can also see some pills or medical tablets scattered throughout the intestinal loops. Then we should know some issues about the use of the barium, which is now became markedly, its use is markedly regressed in the clinical and in the diagnostic purposes because of the widespread use of the endoscopy, as well as the availability of many techniques that can be performed using the modern CT machines. You know that barium provides usually a map for the area to be examined by endoscope later on, and barium can show the site of the lesion, whether it is in the esophagus, in the stomach, or elsewhere in the gut. Then barium can predict the nature of the lesion, whether it is benign or malignant. Sometimes it can say that, and in many cases the endoscope usually cannot see outside the bowel lumen. You know that the endoscope see only inside the bowel, but barium can see inside and outside. Then endoscope cannot bypass a tight stricture, but barium, being a fluid, can pass these strictures. Then barium can determine the length of the lesion, and it can reach some parts of the bowel where the endoscope cannot reach these parts of the bowel. And finally, many patients do not like the endoscope but may accept the examination with barium. And you know that barium is provided previously as powder, which is added to some amount of water to reach a certain consistency of this barium, either barium paste or barium fluid. Then nowadays barium is provided in these bottles, and these are disposable, used for a single bottle for a single patient. Then sometimes you cannot use barium to examine the gut because of fear of the presence of perforation. And you know, barium may get outside the gut through the perforated area, and at that time water will be absorbed from barium, and it will result in the presence of something like calcification or stones within the peritoneal cavity. And in cases of suspected perforation or anastomotic leaks in the gut, you can use this water-soluble contrast material, which is known as gastrografin. And this gastrografin, if it is passed outside the gut, it will be absorbed, then excreted by the kidney later on. Then generally we have some principles for examination of the gut with barium, and whenever we are able to have what's known as the double contrast examination, we can do this. This examination is easily obtained in the stomach and is as well as in the colon. This the contrast examination is performed by introducing barium and air inside the part to be examined. Then you can have a mixture of air and barium in order to demonstrate carefully the mucosal folds and to see if there is any mucosal lesion like ulcers, for example. And meanwhile, you can, through barium, you can identify the filling defects in the organ to be examined. Then we have four main pathologies throughout the gut, which are the filling defect, the ulcer, the diverticulum, and the stricture. Then what do you mean by a filling defect? In filling defect meaning that there is a mass inside the lumen of the gut which prevents barium from filling this area. Then you got a filling defect like this, which indicates the presence of a soft tissue mass within this esophagus, for example, and you see this mass inside. This is what we call intraluminal filling defect. And also an extraluminal filling defect can be produced by a lesion which comes from outside the gut, compressing the wall of the gut and encroaching on the lumen of the gut. As you can see here, these are prominent osteophytes around the spine, compressing the posterior wall of the esophagus, producing this extraluminal filling defect. Then the stricture means that the lumen is narrowed by a lesion, and we have two types of stricture. This one, which is known as rat tail stricture, it is a smooth type of stricture and tight, as you can see, and this stricture may be benign and may be malignant. But the second type of the stricture, which is known as the apple core, it simulates the apple core actually, and this is almost diagnostic of a malignant lesion anywhere in the gut. In the colon, as you can see here, this is the ascending colon, and you got apple core configuration in the ascending colon, diagnostic of a cancer, and this is also applies for the esophagus as well. Then diverticulum is a protrusion through the lumen of the gut, and this is continuous with the gut lumen. Then if you introduce barium, this diverticulum will fill also with barium. And by ulcer, we mean that there is an area of mucosal injury like this one, and whenever you introduce barium, barium will collect into this area or ulcerated area. And if you look to this lesion on FUS from anteriorly, and you can see this collection of barium which will be persistent in all images. And if you look from the lateral side, then you can see a small projection outside the contour or the wall of the bowel, projecting like this, diagnostic of an ulcer. Then we'll apply these terminologies to the esophagus, and the esophagus is examined by what's known as barium swallow. And by barium swallow, we mean we introduce barium based into the esophagus, and we monitor the flow of the barium bolus through the esophagus, and we have images when the esophagus is full of barium to look for strictures, looking for filling defects, and also we have images when the esophagus is empty, looking for mucosal lesions like ulcers or esophageal varices, for example. Then the normal mucosal folds of the esophagus are 3 longitudinal mucosal folds like this. And this is important because if a part of the stomach is above the diaphragm, the number of mucosal folds will increase. Then you know that this is not belonging to the esophagus, but it belongs to the stomach, hence the diagnosis of hiatus hernia, as we will see. Then in the esophagus, we would like to give some information about esophageal webs, esophageal diverticuli, achalasia of the cardia, esophageal strictures, and the reflux esophagitis, the types of hiatus hernia, what's known as diffuse esophageal spasm or corkscrew esophagus, esophageal infection, and the varices. And finally, we have some words about the esophageal neoplasm as well as esophageal perforations. We start by the esophageal webs, and these webs can be congenital and can be acquired. They are in the form of thin membranes that may range in thickness about 2 to 3 millimeter, and they usually result in pain and sometimes dysphagia. Then congenital webs are usually located in the middle and inferior third of the esophagus, while the acquired webs are usually located in the upper part of the esophagus. And these webs are commonly associated with this syndrome, which is known as the Plummer-Vinson syndrome. And this syndrome is in many cases associated with chronic iron deficiency anemia. And you know that about 10% of the patients with Plummer-Vinson syndrome may develop an esophageal cancer. And this is an example of a patient presenting with dysphagia, and this is barium swallowing. You can see the site of the web in the proximal part of the esophagus, and you can easily appreciate the thickness of the web, which is very thin, and you can see the degree of obstruction with dilatation of the esophagus proximal to the site of the web itself. Then this is also a case of Plummer-Vinson syndrome with an esophageal web in the cervical esophagus. While congenital webs are usually located in the lower part of the esophagus, and this is the most common esophageal web in the lower esophagus, which is known as Chudjetsky ring, and this is the incidence, which is seen in 0.2 to 14% in general population. This is the circumferential ring in the lower part of the esophagus, and it occurs at the junction between the esophageal mucosa and the gastric mucosa, and this ring is usually associated with hiatus hernia. This is the typical appearance of the ring, and the distal to the ring you can see part of the stomach above the diaphragm, and this is the associated hiatus hernia. There are theories for the development of this ring, like the congenital etiology and the enfolding of redundant mucosal esophageal mucosa, or stricture caused by reflux secondary to this hiatus hernia. All these are theories for this ring. This is the typical appearance of the Chudjetsky ring, and you see the ring here, and this part is part of the stomach, which is located above the diaphragm, diagnostic of the commonly associated hiatus hernia. This is also the example of the Chudjetsky ring, and you know, this is the site of the ring itself. And in some books you may read about in A ring and B ring. The B ring is the true Chudjetsky ring, but this A ring is just let us say some of the constriction here above the original ring, as you can see in this particular case. Then we came to the esophageal diverticuli, and we have three types. The upper esophageal diverticulum, which is known as Zenker diverticulum, the mid esophageal diverticuli, and the lower esophageal diverticuli, which are known as epiphrenic diverticuli. As I have mentioned before, the diverticuli are just secular outpouching from the esophageal lumen, and usually they are filled with barium, and most of the esophageal diverticuli may be asymptomatic, but you know the common complications of diverticular are perforation and stagnation of food and sometimes regurgitation. Then this is the zinc-diverticulum, which is a false diverticulum. And you can remember that the diverticuli in the upper esophagus and in the lower esophagus are false, while the diverticulum in the middle part of the esophagus is the true diverticulum. And the true diverticulum meaning that it is formed of the wall of the diverticulum is formed of the all three layers of the esophageal wall. But the false diverticulum is only formed by the mucosa, and this is a protrusion through the dehiscence between the pharyngeal constrictor muscles, and you can see the typical location posterior to the upper esophagus. And this is a barium swallow, and you can see this is the typical appearance of the diverticulum in the upper esophagus or in the lower part of the neck, and the diverticulum is continuous with the line of foot, the cell. Then this is also a classic appearance of zinc diverticulum, and this is also a classic appearance of zinc diverticulum containing barium fluid level. Then you remember that epiphrenic diverticulum, also a false diverticulum, and this is an acquired diverticulum due to increased intraluminal pressure associated with distal obstructive lesions in the esophagus or lower down. Then you see a big diverticulum, and this is not in hiatus hernia because you can identify that the gastroesophageal junction is well present underneath the diaphragm. Then the mid-esophageal diverticuli are true diverticuli formed of all the three layers of the esophageal wall, and they may be due to traction or due to pulsion. Pulsion diverticuli due to increased intraesophageal pressure, and the traction diverticuli are caused by traction on the esophageal wall, usually by inflammatory lymph nodes in the mediastinum. And this is an example of a mid-esophageal diverticulum, which is a true diverticulum, contains all the three esophageal layers, and the traction diverticulum from fibrous adhesions by lymph node infection, which are usually secondary to TB. This is also an example of mid-esophageal diverticulum. Then you came to the rare condition which is known as intramural pseudo-diverticulosis. And this is the diverticuli are associated with chronic obstructive changes, and it represents the passage of the barium through the wall of the esophagus, forming these pockets filled with barium. And these pseudo-diverticulosis can be easily identified by endoscopy, as you can see, and also can be seen by the barium study. And these pseudo-diverticuli are commonly associated with candida infection of the esophagus, and this is the percentage of association. The cause of these diverticuli is not known, and as I have said, this is a rare disorder which is usually seen in the 7th, on the 6th, on the and 7th decades of life, and is more common in males. Other associations other than candida include diabetes, reflux esophagitis, and alcohol abuse. Then we came to the achalasia of the cardia, which means that there is narrowing of the distal part of the esophagus due to neuromuscular incoordination, which is the primary type. Then the secondary type is usually due to a known cause like malignancy, or in cases of Shage's disease, or sometimes with diabetes mellitus. The esophagus has difficulties to empty into the stomach, then it will food will stagnate, and by time this will result in a huge dilatation of the esophagus proximal to this narrow segment. And this huge dilatation usually can discriminate achalasia, which is a benign lesion, from a stricture, malignant stricture in the distal esophagus, because the malignant structure do not allow time for the esophagus to reach this huge dilatation. And the ideal method of treatment of achalasia is to use the endoscope, or even by surgery, to cut down this area of the muscles in the esophagus, and to disturb remove this neuromuscular incoordination. Then by time, this is a benign lesion, and it may stay for years with little manifestations, and the esophagus proximal to this segment of narrowing will be hugely dilated up to, it is sometimes called the sigmoid esophagus, or which simulates the sigmoid colon. And if you have the barium study, you will see that the esophagus is markedly dilated and the distal part is narrowed, giving the rat tail configuration with the smooth borders. And if you have the CT scan, you will see the esophagus is markedly dilated with some air fluid level due to the presence of food and drinks inside the esophagus. Then we came to the strictures, and we have 4 types of strictures: the corrosive stricture, peptic stricture, malignant, and traumatic strictures. The corrosive stricture is due to the swallowing, accidental swallowing in children of some corrosive material, and in adults maybe due to attempts for suicide, for example. And then you know that the corrosive stricture is usually a long, smooth stricture, and it usually starts at the level of the arch of the aorta, where there is some delay of the barium bolus at this level due to compression of the esophagus by the arch of the aorta. And because we are afraid of esophageal perforation, and we usually used to give these patients, instead of barium, we give them lipiodol. And this lipiodol is an oily material which is safe if it passed outside the esophageal lumen, just in case there is an esophageal perforation secondary to corrosion. And if we are sure that there is no perforation, we can use barium later on. Then the malignant stricture is, as I have said, similar to the apple core configuration anywhere in the gut. And you see this is the mid part of the esophagus, and you can see we call this in radiology, this is the proximal shoulder and the distal shoulder, like this apple core exactly. And whenever you see this, you are almost diagnosing a malignant stricture. Then the peptic stricture is usually found in the distal part of the esophagus, and is secondary to repeated gastroesophageal reflux, which will result in injury of the esophageal mucosa, and later on by fibrosis, then ending by this benign stricture with smooth edges, and the history is almost diagnostic. In gastroesophageal reflux, meaning that the contents of the stomach can be easily passed retrograde into the lower part of the esophagus. And the gastroesophageal reflux does not need the Trendelenburg position, or putting the head of the patient down and the feet high up in order to look for reflux, but just look at the esophagus in the resting phase. There should not be any barium in the esophagus in the resting phase. But in this case, you see the esophagus is markedly dilated, and also the gastroesophageal junction is batulous, and barium passes easily into the lower part of the esophagus, and this can be also monitored under screen control. Repeated attacks or repeated gastroesophageal reflux will result in reflux esophagitis, and this is the progressive disease starting by nodular or granular appearance of the mucosa, which is caused by the edema and inflammation secondary to contact with the gastric juice. Then later on, these edematous folds will be thickened, and irregular. As you can see, the folds of the esophagus are very thick and of irregular outline. And after that, they will develop some of the superficial ulcerations where some buckets of barium can be seen within the esophageal wall. And later on, these ulcers will be long and irregular. As you can see, they look like flowing material or the flowing wax like this. And after that, there will be a scar tissue and multiple saculations, which you can call it pseudodivertically due to deep ulcerations in the wall of the esophagus. And later on, there will be develop the stricture itself, which is the peptic stricture, as I have said. Then sometimes the persistence of the gastroesophageal reflux will result in columnar metaplasia of the esophageal mucosa, and this is known as Barrett esophagus, which is a pre-malignant condition, as you all know. And this is the result of long-standing reflux esophagitis, and you can diagnose this appearance as Barrett esophagus by these three main findings. Number one, mid or high esophageal ulcers. Number two, mid or high esophageal web-like stricture, and you see the stricture is very high in relation to the gastroesophageal junction. Then the reticular mucosal pattern, and you see this is not the mucosal pattern of the esophagus. You remember, the esophageal mucosa are formed of three longitudinal folds, but now you cannot see these folds. Instead, you see this pattern of reticular mucosa. And this diagnosis can be easily reached by endoscope. And you remember the presence of a relatively high esophageal stricture is suggestive, together with the abnormal appearance of the mucosa. And this is also abnormal appearance of the mucosa in the distal part of the esophagus, which is suggestive of Barrett that can be confirmed by endoscopy and biopsy. Then the hiatus hernia, meaning that part of the stomach or the gastroesophageal junction is above the diaphragm. And this film is very common in the exams, where you can have this frontal x-ray and look carefully behind the heart, and you can see this opacity. And if you look very carefully, you see air fluid level. Then you know that this is the hiatus hernia. And in the lateral view, you can see this shadow posterior to the heart, corresponding to the region of the gastroesophageal junction. Actually, there are four types of hiatus hernia. The most common one, which is seen in the clinical practice, is known as the sliding hiatus hernia, which means that the gastroesophageal junction and the part of the fundus of the stomach are above the diaphragm. And the type 2, which is rare, where the gastroesophageal junction is below the diaphragm and part of the fundus of the stomach is above the diaphragm posterior to the esophagus, and this is known as para-esophageal hiatus hernia or rolling esophageal hiatus hernia. Then the type 3 is the combination of these two. The gastroesophageal junction is above the diaphragm, part of the gastric fundus is above the diaphragm, and also a good part is seen posterior to the stomach. Then type 4, meaning that type 3 with some other organs herniating with the stomach, like the small bowel, the mesentery, as you can see here. Then the type 1, which is the most common type, means that the gastroesophageal junction is above the diaphragm. And this is a good example of type 1 hiatus hernia. And you can see the gastroesophageal junction is above the diaphragm and also part of the stomach. And type 2, you can see the gastroesophageal junction is below the diaphragm and part of the stomach is herniating posterior to the esophagus above the diaphragm. This is rare and represents less than 5% of all hiatus hernia. Then type 3 is also commonly seen in the clinical practice, where the gastroesophageal junction and part of the stomach and part of the gastric fundus are seen above the diaphragm. And this is type 3 hiatus hernia. The gastroesophageal junction is above the diaphragm, together with a good part of the gastric fundus above the diaphragm. And type 4 means that the hiatus hernia contains other tissues other than the stomach. And in this case, you can see part of the colon is herniating through the hiatus. Also, hiatus hernia can be identified in the pediatric age group, and the hiatus hernia have the same complications in children as similar to those complications in adults, including esophagitis, shortening of the esophagus, stricture, vertical ulceration, esophagus, and malignant transformation. Then diffuse esophageal spasm, meaning that there are in coordination of the contractions and the relaxations of the esophageal wall, resulting in appearance of corkscrew esophagus, and this will result in episodes of dysphagia and chest pain due to abnormal esophageal contractions. And you can see this is a classic appearance, is usually seen in elderly patients, and you can see that there are numerous contractions through the esophageal wall. And by manometry, you can see this. You can measure the pressure through the esophagus, and also you can monitor these contractions, which are not usually propulsive. They are uncoordinated contractions, resulting in this corkscrew appearance of the esophagus. Then Candida esophagitis is the most common cause or the most common type of infection in the esophagus. And of course, being a fungus is usually seen in immune compromised patients, especially those with AIDS. And this oral thrush, where you can see this in an appearance, is commonly associated with Candida esophagitis. However, 50% of the patients do not show this thrush. And the appearance of the Candida esophagitis is almost classic in barium swallow, and you can see this shaggy appearance of the esophagus, and you remember the association with intramural pseudo-diverticulosis as well. And you can see some plaques in the wall of the esophagus, which represents these swelling defects, abnormal motility, and thickened folds, like these thickened folds, and of course the shaggy outline of the esophagus. Then you can see this, let us say, typical or diagnostic appearance of the Candida esophagitis. Then we came to the scleroderma, and you remember that scleroderma will result in atony of the esophageal muscles, and this will end by tube-like esophageal dilatation, which involves the whole esophagus, as you can see. And sometimes the gastroesophageal junction remains unaffected, and in this case you may have similar findings to those of Achilles. And this can be also identified in the chest radiograph, because you know that in the chest radiograph, this is the esophagus, as you can see, which is markedly dilated and filled with air. This is not usually seen in normal population, since the esophagus is usually collapsed and may contain a little amount of air in a small part of it, not throughout the whole esophagus. But if you see this finding, especially in the lateral view, you can assume the possibility of scleroderma, and you can confirm this by the presence of other stigmata of scleroderma in the skeleton, for example, or in the skin, for example, or by endoscopy. Then esophageal varices are the result of portal hypertension with dilatation of the portosystemic collaterals, usually produce worm-like filling defect in the esophagus. And this can be easily identified by barium, and also can be easily identified by in the CT scan. And you know that there are two types of esophageal varices: the downhill esophageal varices, which are relatively uncommon, and the uphill esophageal varices, which come from the lower down. Then you see this uphill esophageal varices, which are more common, and it affects the lower part of the esophagus, and the causes, as you can see, portal hypertension, splenic vein thrombosis, obstruction of the hepatic veins, portal vein thrombosis, IVC obstruction below the hepatic veins, and splenomegaly. Then downhill esophageal varices will result from obstruction of the superior vena cava. And you know that these are varices affecting the upper third of the esophagus, and the upper third drains through the azygos vein into the superior vena cava. Then any obstruction of the superior vena cava will result in what is known as downhill esophageal varices, which affects the upper part of the esophagus. And the causes of superior vena cava obstruction are lung cancer, which is the most common, and sometimes lymphoma and other mediastinal tumors, or even fibrosis. This is typical appearance by barium study showing the worm-like filling defects throughout a good part of the esophagus, representing esophageal varices. And this is the CT appearance of esophageal varices, and you can see this is the site of the esophagus, identified by this loculus of air surrounded by markedly dilated vascular structures representing the portosystemic collaterals at the gastroesophageal junction. And this is also a good example by barium showing extensive esophageal varices. Then we came to the esophageal neoplasms, including the benign and malignant lesions. The benign lesion on top is the leiomyoma of the esophagus, which is the most common benign tumor of the esophagus. And this leiomyoma is usually asymptomatic. It grows mainly outside the lumen. It grows from the wall and extends outside the lumen of the esophagus. And the leiomyoma is usually solitary, and sometimes may be multiple. The leiomyoma, as I have said, is a benign lesion which has an eccentric growth outside the lumen. And you see this very smooth impression, and the rest of the tumor will be outside the lumen of the esophagus. And you can remember that this is the only calcified esophageal tumor which may contain matrix calcification, and sometimes it has an ulcer which will, like this case, and this is the leiomyoma of the esophagus, and this collection of barium is lying in the ulcer on the surface of this tumor. This is an appearance of leiomyoma of the esophagus, having this smooth impression on the wall and this relatively dilated lumen. In the CT scan, you can see this is the site of the esophagus identified by this air loculus, and this is the tumor which grows outside the esophageal lumen. Then we came to the esophageal cancer, and the cancer esophagus, according to the literature, is relatively uncommon. Less than 1% of all cancers, and about 4 to 10% of GIT malignancies. And males are affected more common than females, and the common presentation is by dysphagia. Then you remember that the cancer esophagus presents by a stricture or even a mass filling defect inside the esophagus, but commonly by a stricture, and these are the predisposing factors: achalasia and Barrett esophagus, celiac disease, ionizing radiation, caustic stricture, Blammer-Vinson syndrome, you remember 10%, alcohol and tobacco, oral and pharyngeal carcinomas. Then actually you have the most common histologic type, which is the squamous cell carcinoma, representing up to 95% of all types of esophageal cancer. Then you got the adenocarcinoma, which is less common, and other much less common malignancies like mucoepidermoid, adenoid cystic carcinoma, spindle cell sarcoma or carcinoma, leiomyosarcoma, rhabdomyosarcoma, and other malignancies. Also, you remember lymphoma, which is one of the tumors of the gut. It affects the esophagus and other parts of the gut. Then cancer esophagus will present by commonly by a structure which is in the form of apple core with destruction of the mucosa at the site of the lesion, narrowing of the lumen, and irregularity of the border. Then in this particular case, the patient also has a smooth structure in the distal part of the esophagus, which is attributed to repeated gastroesophageal reflux. And this is an appearance of rat tail configuration of the distal part of the esophagus. But if you look carefully, you can see that the esophagus proximal to the structure is not markedly dilated, is moderately dilated. And then you should have an endoscope to exclude the possibility of carcinoma, which may be sometimes misdiagnosed as achalasia from radiography, but the clue is the dilatation, the degree of dilatation of the esophagus proximal to the stricture, which is usually mild in cases of carcinoma. Then in the era before the CT scan and the other imaging modalities, they used to use the chest radiograph for findings which can help to suspect the presence of esophageal cancer, but most of these are now unreliable. Then you can look for the case of achalasia and a case of carcinoma of the esophagus. And then in cases of the achalasia, the structure is smooth and the esophagus is considerably dilated proximal to the structure itself. And in cases of carcinoma, the structure is relatively irregular. There is some shouldering in the proximal part of the esophagus. And in this case, you can see also moderate dilatation of the esophageal lumen. And I should say that there is a degree of overlap between the appearance of achalasia and the stricture in the distal part, the malignant stricture in the distal part of the esophagus. And in all conditions, if the history is not typical and the radiographic appearance is not classic, there should be an endoscopic examination and biopsy to confirm the diagnosis. And by CT scan, you can see cancer esophagus as a circumferential thickening of the wall of the esophagus, markedly encroaching on the esophageal lumen. And this is the appearance of carcinoma of the proximal part of the esophagus. And by barium study, and you can see this irregular appearance of the mucosa, and you see the filling defect. The wall of the esophagus should pass like this, and there is a good part of the esophagus which is occupied by this lesion, which produce destruction of the mucosa, highly suggestive of esophageal carcinoma. Then esophageal lymphoma, one of the patterns of lymphoma in the whole gastrointestinal tract is the diffuse mucosal thickening in a significant degree like this. And this is the esophagus, and you see that the mucosa is markedly thickened, and it does not usually produce obstructive changes, especially in the esophagus, but you may predict the lesion by this. You can see huge thickening of the mucosa, and this may also extend into the stomach in a combined lesion of the affecting the esophagus and the stomach as well. And this is also one of the appearances of esophageal lymphoma, where you can see filling defects which may produce irregularity of the esophageal lumen, and they occur at multiple levels. And you remember, the carcinoma does not produce multiple levels of narrowing or mucosal destruction, and you may suspect the possibility of lymphoma from this appearance and from the fact that there is no evident esophageal obstruction. Then you look at this example here, you see there is marked narrowing of the esophageal lumen here, but there is no proximal dilatation, and in the CT scan it simulates actually the appearance of the carcinoma, and this is the esophageal lumen containing some amount of contrast material, and this appearance will need further evaluation by endoscopy to be sure about the nature of the lesion. Then this is also a CT scan showing this is the lumen of the esophagus, and this is the mass affecting the esophageal wall, and this mass is eccentric. As you can see, this wall is relatively thickened, but this is markedly thickened by this neoplastic mass. And you cannot say for sure that this is lymphoma, but you may say that this is an esophageal tumor, which is warranting further evaluation by endoscopy to assess the nature of the lesion. Finally, we came to two important lesions. The first of them is Mallory with tear of the esophagus, which is a non-traumatic tear at the gastroesophageal junction, which results from aggressive or vigorous vomiting or cough. And this will result in a mucosal tear in the esophagus and will result in bleeding. And this bleeding can be cauterized or used in endoscopic clipping, for example, and rarely it may need some embolizing material. Then if you look in this barium swallow, and you can see some longitudinal ulcer or tear in the distal part of the esophagus. And in absence of good clinical data, you may mistake this for an ulcer secondary to gastroesophageal reflux. But in cases of typical history of vigorous coughing or vomiting that has been complicated by bleeding, then you know that this is a tear in the esophagus. And then the final issue is esophageal perforation, which may be iatrogenic sometimes due to introduction of endoscopes or some of the catheters, for example, or maybe due to trauma by stab wounds and penetrating injuries, and rarely it may be secondary to blunt trauma to the chest and compression. And sometimes the esophagus may rupture secondary to severe vomiting and straining. And the non-traumatic causes also include rupture due to neoplasm or caustic or corrosive ingestion. Then in infants, the rupture of the esophagus is frequently due to passage of tubes, and it usually affects the proximal part of the esophagus. Then this is the barium swallow, and you can see the site of perforation with extra luminal passage of the esophagus of the barium into the mediastinum. And this is also esophageal perforation, and this non-traumatic esophageal perforation usually seen in men around the age of 50 years, but it also seen in the pediatric age group. The tears are usually vertically oriented and may reach about 4 centimeters in length. 90% occur along the left posterolateral wall of the distal part of the esophagus near the gastroesophageal junction. And this is the clinical triad for diagnosis, which include vomiting and chest pain, subcutaneous emphysema due to passage of air from the esophagus into the mediastinum and hence in the subcutaneous area. This is stated in the literature that without any treatment, death may occur in about 90% of cases during the first 48 hours. هذا وبالله التوفيق والسلام عليكم ورحمة الله, and thank you very much.